Greetings. I am Dr. Bridget L Cox Striker. As an associate clinical instructor and as one of the Transplant Procurement Coordinators, or TPMs, of the Port of Spain General Hospital in the Northwest Regional Health Authority, I wish to welcome and thank all participants and all presenters who are gathered virtually to celebrate World Kidney Day 2022 via this public symposium. This year, our theme is Kidney Health for All, bridging the knowledge gap to better kidney care. I would like to thank the University of the West Indies, the Department of Clinical Surgical Sciences of the Faculty of Medical Sciences, Ms. Marsha Ivey, Associate Dean, Public Relations, Mrs. Wendy Maynard, Marketing and Communications Officer, and Dr. Sandra Reed, Acting Dean, for partnering with us to continue our annual education on kidney health for all categories of staff and for the public. This education is particularly relevant during the current COVID-19 pandemic, which itself has contributed to new cases of acute and chronic kidney disease and limited or normal face-to-face engagement. Education is power. Education bridges knowledge gaps and empowers people to make sound kidney health choices and lifestyle choices. Education will prevent and reduce the non-communicable disease or NCD burden on our health allocation, decrease disease severity and complications, and improve our quality of life. I now introduce our two chairpersons for the first of our two sessions. Dr. Dave Harananan is a vascular surgeon, transplant surgeon, and lecturer of the University of the West Indies. He is based at the Eric Williams Medical Sciences Complex. Nurse Jolene Moore has been an ICU nurse for over 6 years and is a trained transplant procurement coordinator for just under 3 years at the Port of Spain General Hospital. She has been a part of the COVID-19 response team at the COVID ICU at St. James Medical Complex. Welcome, Dr. Harananan and Ms. Moore.
Hi, good afternoon all. And again, I'd like to welcome everyone to this proceedings dealing with World Kidney Day. Just to put things into perspective as we wait for more and more attendees to enter, I thought I'd just highlight a couple of the problems that we face with end-stage renal disease in Trinidad and Tobago. It's been said that kidney disease is one of those silent conditions, and it's not uncommon that many of our patients present requiring emergency dialysis, so-called crash landers. And a rough estimate shows that there's about 50 to 60 patients per month that could need emergency dialysis. We have about 1,300 patients on dialysis, some of them on peritoneal dialysis, some on hemodialysis. And these patients are facilitated by about 15 dialysis centers in Trinidad and Tobago. So that's quite a big disproportion, yeah? To maintain one patient on dialysis is roughly about 2,000 US or close to 15,000 TT. And if you were to multiply that, it's a massive sum of money to maintain these patients on dialysis, close to about 27 million US per year. So it's a huge economic burden, it's a huge personal burden, and a huge mental problems. And we're not taking into consideration that many of these patients are not able to work as they should. So that just kind of puts things into perspective. And as such, the topics that have been chosen for the program highlights a lot of these things and helps us to understand how we can manage ourselves before, during, and after we've been diagnosed with these conditions. So to start the proceedings, I would like to now introduce our, to get welcome from Professor Dilip Dan. And it's indeed my pleasure to introduce Professor Dan, who is one of my mentors in surgery. Professor Dan is Deputy Dean Postgraduate Studies at the University of the West Indies, and his accolades are far too numerous for us to elucidate at this point in time. That will take a whole slot of a presentation, so I'm not going to go into that. Professor Dan is an accomplished general, advanced laparoscopic and bariatric surgeon who has worked extensively in the management of obesity in Trinidad and Tobago. I have had the privilege to be a co-author in one of his published articles dealing with metabolic surgery to cure diabetes mellitus in Trinidad and Tobago. And as such, it is quite fitting for him to bring remarks on behalf of the Faculty of Medical Sciences, University of the West Indies, since his work involves non-communicable diseases, and the complication of these diseases ends up being end-stage renal disease. So I'd like to welcome Professor Dan to bring remarks on behalf of the Faculty of Medical Sciences Complex. Professor Dan.
Good evening, and thank you, Dr. Haranan, for those very kind words of introduction. Members of the National Organ Transplant Unit, Transplant Coordinators of Port of Spain General Hospital, staff and students of the University of the West Indies, colleagues, specially invited guests, members of the Police and Judiciary Service, whom I'm told will be attending, members of the public, members of the media. According to the WHO 2018 report, kidney disease deaths in Trinidad and Tobago accounts for 2.5% of all deaths and ranks as the 11th cause of deaths in this country. Morbidity and patients suffering from chronic kidney disease is much higher than this. And what is even higher, as Dr. Haranan rightly pointed out, is the cost of treating kidney disease. And worse yet, there is no cure for the patients, as chronic kidney failure is, for all purposes, irreversible. However, kidney transplantation is the only definitive way to treat kidney failure, and we must aim to improve our transplant rate in Trinidad and Tobago. The causes of chronic kidney disease are directly related to the high prevalence of diabetes and hypertension, the main non-communicable diseases in Trinidad and Tobago. And these are directly related to the rising obesity epidemic. And what is more important is that they are all preventable diseases, and prevention is the best form of treatment for such a horrible condition. So the best way for prevention lies with education, and not just educating the adult population, but our children, so they are made aware of proper food choices and exercise at a very early age. It is with this in mind that the University of the West Indies would really like to commend the organizers of this symposium, the Transplant Coordinators of Port of Spain, the Department of Clinical Surgical Sciences, FMS, UWI, NOTU, in reaching out to the public to increase awareness of kidney disease on World Kidney Day 2022. It is critical that the population understands the value of organ donation, both live and cadaver related, and the need to inform the National Organ Transplant Unit of potential donors. On behalf of the Dean of the Faculty of Medical Sciences, Professor Terence Simangal, it is my pleasure to welcome each and every one to this symposium and to wish you all a wonderful and successful meeting. Thank you very much.
Thank you, Professor Dan, for that warm welcome, giving us information on kidney disease, and hoping that this afternoon you're going to get as much information as possible to make informed decisions about donations and kidney health. Right? With that said, let's welcome our first presenter, Ms. Steffi Spencer. Ms. Steffi Spencer should be presenting the importance of kidneys to life quality and their care. So Ms. Spencer is a registered nurse for the past 10 years, 5 of which were spent in ICU in Port of Spain General Hospital. She joined the transplant team after successfully completing the training in 2019. She is a junior TPN, but is now currently at the COVID ICU in St. James, helping to assist in the COVID response at this time. Ms. Spencer.
As we celebrate World Kidney Day, let's start by appreciating the importance of kidneys to life, quality, and their care. As we know, the kidneys are 2 bean-shaped organs about the size of a fist, located just below the rib cage on either side of the spine. But why do we need it? For life. The kidneys are key to maintaining good body functioning so that we can work, play, achieve our goals, find adventure, and live a full life. But how do they do that? Let's break it down. What do the kidneys do in the body? Fun fact, the kidneys have been known as the filter and the laboratory of the body. The kidneys filter the blood. Through this, they get rid of excess waste that may poison us. And they balance body fluids by removing excess liquids that we don't need. This waste and fluid are passed out as urine. The kidneys, as the laboratory, also produce a number of hormones that assist the body to regulate blood pressure, balance important minerals in the body such as sodium, calcium, potassium, and phosphorus. This balance, in turn, leads to good functioning of muscles, nerves, bones, and blood vessels. They also assist in producing an active form of vitamin D to make bones strong. They also keep acid-base balance so that the body isn't too acidic or too alkaline. And they stimulate the production of red blood cells that our body needs. So we see that the kidneys play a hand in just about everything in the body. Therefore, we must protect them. How do we protect them? By keeping them healthy. It is said that most kidney damage actually results from other lifestyle diseases, such as high blood pressure, diabetes, obesity, and heart disease. So what can I do to keep my kidneys healthy? Get to know yourself and your family history. What is your normal blood pressure, blood sugar, weight, cholesterol? Are you diabetic or hypertensive? Does anyone else in your family suffer from these things or have a history of kidney disease? These are the important questions to discuss with your family. Whether you have a lifestyle disease or not, you should get regular checkups at least once per year with your doctor to make sure your kidneys and your body are at their best. Exercise daily. This controls weight gain and prevents high blood pressure as well as keeping you fit. Hydrate, hydrate, hydrate. This means drinking about 4 to 6 glasses or around 2 liters per day of clean drinking water. Definitely no less than 1 liter. Pee all that you can pee. Holding your urine may actually cause infections and damage the kidneys. So when you gotta go, you gotta go. Eating a healthy, balanced diet and cooking wisely. Minimize the salt and added sugars. Use more natural spices for flavor instead. Make sure you get in your servings of fruits and vegetables, whole grains, and nuts. Eat small portions of proteins, and instead of frying, grill, bake, roast, or stir fry as healthier options. Cook with non-stick cooking spray or a bit of olive oil instead of butter. And trim the fat from the meats. Quit smoking and vaping. The nicotine and chemicals are toxic and damage the blood vessels. Avoid self-medication. Be careful with taking too many supplements and herbal remedies. Avoid prolonged use of over-the-counter painkillers and NSAIDs. Don't take anyone else's medication unless prescribed for you by a doctor. And the medication that you are prescribed, take them correctly as prescribed. No doubling up or missing doses. Don't do drugs. Street drugs like cocaine actually cause kidney disease too. Drink in moderation. If you do drink alcohol, that means about 1 drink per day for women and 2 for men. Get enough sleep. During sleep, the body takes the time to recuperate and reset for the next day. Stress-reducing activities. We have all felt the emotional, mental, and physical effects of stress on the body, including the kidneys. Try to make time to unwind regularly. To help you with getting to know yourself, here are some of the normal numbers to compare yours to. Blood sugar should be less than 100 before eating a meal, and 2 hours after eating, it should be less than 140. Blood pressure should be around 120/80. Blood cholesterol should be less than 200, and body weight, BMI, measured in body mass index, should be less than 25. We know now what to do, so let's make the effort and strive to keep our kidneys healthy and live life to the fullest. Thank you.
Thank you so much for that. And now we will move on one time to the other presenter. And it's a huge privilege to introduce the next presenter, who is Dr. Leslie Roberts. She's a fellow of the Royal College of Physicians of Canada, which following she had completed her internal medicine and nephrology degree in the 1990s. She started renal services at the Eric Williams Medical Sciences Complex, and she was the first medical director at the National Organ Transplant Unit. From December 2005 to February 2017, she held this position and has been hugely instrumental in bringing this service into the public healthcare system. And I like to tell her that she's been the face of transplant for many, many years, carrying it on her shoulder. So I've told her that over and over. She's interacted with many international organizations, Donor Transplants Institute of Spain, Transplant Link community in Manchester, UK, and among others. She's interacted with many international surgeons to help develop our national organ transplant program, and she's done a sterling work towards achieving this. She continues to work in the public system by assisting with renal clinics in Tobago, and she's supported Antigua and Barbuda in the care of their renal patients until they started their own nephrology team. And she does similar work with Cayman Islands. Dr. Leslie Ann Roberts is one of our stalwarts, a massive personality in renal disease and in organ transplantation. And it's indeed a privilege for us to hear from her. So we move on to her talk now. Thank you so much.
Greetings. I would like to thank the organizers for asking me to participate in the celebration of World Kidney Day 2022. This year, the theme is bridging the knowledge gap to allow for better kidney care. To this effect, I will be presenting today when kidneys fail, the causes, the impact, and care options. I would also like to take this opportunity to thank Ms. Pesnel Sanka for allowing me to use some of her slides. When one's kidneys have not been functioning for at least 3 months satisfactorily, one is said to have been suffering from chronic kidney disease. Chronic kidney disease has 5 stages. These stages are dependent on the degree of malfunction of the kidney. We know that what is clinically significant to both the patient as well as the physician are those kidneys that fall in stages 3, 4, and 5. In stage 5, which is just at the tip of the iceberg, as you see here, patients often require dialysis. Chronic kidney disease can affect all ages. We can say it is a disease from the cradle to the grave. 10% of the general population has chronic kidney disease, and the majority of these people are over the age of 55. Who are the people who are at risk of developing kidney failure? Well, the 4 primary ones are people who suffer with diabetes mellitus, people who suffer with hypertension, those who are obese, and those who have cardiac problems, particularly if they are of an ischemic nature. Other people do get chronic kidney disease And some of these will include the young children who are born with congenital abnormalities of their urogenital tract, those who may have had some degree of acute kidney injury in the past and go on later to develop chronic kidney disease, those who have a hereditary problem because of a genetic malfunction, such as autosomal polycystic kidney disease or Alport syndrome, people who have primary glomerulopathies as well as the secondary ones, and the commonest one we know of is systemic lupus erythematosus, and in the older age group, men who may have benign prostatic hypertrophy or even prostate cancer or bilateral renal calculi. What is the impact that chronic kidney disease has on the population or the world? Chronic kidney disease is a global health problem. It affects 850 million people. As a matter of fact, 1 out of every 10 adults over the age of 50 has chronic kidney disease, and it is known to be the fastest rising cause of death. We expect that by 2040, it will be the 5th leading cause of death. Why is this happening? This condition is being fueled by the marked increase in incidence of type 2 diabetes mellitus, hypertension, and obesity, all caused by urbanization of our diet, our lifestyle, and somewhat our genetic predisposition. The burden of disease is substantial given its financial impact, its societal issues, its morbidity, and mortality. Within different countries, particularly between the high-income countries and the lesser and medium-income countries, there are differences in the burden that chronic kidney disease conveys. We find that in 2010, greater than most of the people over the age of 20 who had chronic kidney disease were in the lower middle income countries as compared to the higher income countries. Acute kidney injury, which is a forerunner of chronic kidney disease, affects 13 million people per year, and of these people, 85% of them are found in the lower middle income countries. So therefore, there is a significant burden in the lower middle income countries. But the impact on the society is even greater, I would believe. The impact on the society can be looked at in two ways: the impact on the economy and in the country, and the impact on the family. Firstly, we find that there's a lack of productivity both with the victims as well as the caregivers, which ultimately results in a reduction of earning income, both to the individual and the country. There's caregiver burnout because the constant care of these chronic patients leads to burnout. The impact on the family function and roles is exceptionally significant. Here we find a dysfunction and a change in the function that the family now sees. The roles are different. The children now become the providers and the parents now become the children. And for the male man and for the male people, they feel they suffer some degree of loss of self-esteem and manliness. So, what happens then if you do all that you can to prevent the disease, but you still end up in stage 5? Then you need kidney replacement therapy, of which there are 2 modalities. One modality is dialysis. A second modality is that of transplantation. Hemodialysis and peritoneal dialysis are the 2 modalities. Hemodialysis is the most common type of dialysis that is practiced in all countries. And here in Trinidad and Tobago, we are no exception, although both peritoneal dialysis and hemodialysis are available. It's always the patient's choice, and what we find is that the medical doctor tends to make some recommendation as to the suitability of peritoneal dialysis or hemodialysis for the patient. As I mentioned before, over 80% of chronic patients are receiving in-center hemodialysis. And there's such a structure called home hemodialysis, which only seems to be well established in higher income countries. Peritoneal dialysis first. Would this policy work with us? It does in some countries which are very similar to ours, where the majority of people are in the Jalisco region in Mexico and in Guatemala receive peritoneal dialysis. This can be a cost-effective way of providing dialysis, and in addition, because of the mortality rate, which is quite predominant in the first few months of starting hemodialysis, because of lack of access to pre-end-stage renal disease care, this may be a route to go for us. Kidney transplantation is really the most cost-effective kidney replacement modality that is available and always results in a better clinical outcome than dialysis. However, for a transplant to occur, a human donor is always required. This donor might either be a living one or a deceased one, a living related or a living unrelated, somebody who wants to give a kidney because of altruistic purposes or in a whole paired exchange program. Dr. Lynch will give you later on a brief rundown as what happens in Trinidad and Tobago with regards to transplantation. There is always, no matter where you go, a supply and demand issue, and xenotransplantation, which is transplant across animal species, has been considered to overcome the supply and demand issue. Recently, you would have seen that we used a genetically engineered pig's kidney in a human transplant. Wow, chronic kidney disease has such a wide scope, has such devastating effects to the country, to the individual, to the family. What is the way forward? The way forward, we feel, is that you need to implement effective and affordable programs which will deal with early detection, prevention, and treatment of people with chronic kidney disease. The 4 pillars of devastation, hypertension, diabetes mellitus, obesity, and cardiovascular disease have to be aggressively managed, usually with the blockade drugs which block the renin-angiotensin system and newer anti-diabetic medication. Prevention of acute kidney injury and keeping people who have had acute kidney injury within the radar will help stem the progression of chronic kidney disease. We must note that the number of people who die prematurely because of lack of access to care is usually 3 times more than the people who actually receive treatment. Most of these people lie in territories very near to us, and as such, we need to bear this in mind when we think about programs within our country. Chronic kidney disease is no easy task. It is with us, and it will always be with us. We need to bridge the gap if we are going to improve healthcare for all. I am available for any questions. Thank you.
All right, so thank you, Dr. Roberts. So we will be having a question and answer session at the end of our first session. So let's hold the questions until afterwards, right? Okay, so next presenter we have is Dr. America Ram Saran. She is a specialist anesthetist and intensivist attached to the Port of Spain General Hospital. She graduated from the University of the West Indies and the St. Augustine campus in 2004, of bachelor's in medicine and bachelor's of surgery. She went on to pursue a doctorate in medicine in anesthesia and intensive care, which she did in 2016. She continues to pursue her learning, and she did an online course for the TPN program and became a TPN in 2018. She had further education done in anesthesia and intensive care in ultrasound training in the UK and the US. She is also a certified advanced trauma life support instructor. Ms. America has participated in numerous kidney health and organ donation talks, which are targeted to many categories of staff, whether it be hospital, outpatients, pharmacy, families, the public, right? So she has a lot of knowledge and information for us, right? So can I welcome Dr. Ram Saran?
On the second Thursday of March each year, World Kidney Day is celebrated. This day is part of a campaign to raise awareness about the importance of our kidneys to our overall health and to reduce the frequency and the impact of kidney disease worldwide. The intent of this presentation is to illustrate how healthy persons can make a difference and improve the lives of those living with kidney disease by the gift of giving. Persons needing transplants are usually very ill or dying because their own organ is failing. Unfortunately, even with advances in tissue engineering, we are not able to grow organs in labs at this point. Only a donor can provide an organ for transplant into a recipient. Organ donation is an opportunity to help others and save lives. Donors can be either living or deceased. A single deceased donor with their organs can save 8 people, 2 of which are persons living with kidney disease. A single deceased donor can also save over 50 people with their tissues. A single living donor can donate 1 kidney once and help 1 person. Also, did you know that the liver has a unique capacity to regenerate itself? In fact, a small part of the liver of a living donor can help a small child with no adverse effect on the donor. Did you also know that we have a national organ transplant unit right here in Trinidad and Tobago? Our National Organ Transplant Unit has been in existence since 2006, and to date, NOTU has done 195 kidney transplants from both living and deceased donors. There is no charge to either the donor or the recipient under the Ministry of Health National Organ Transplant Program. Organ donation is free. Currently, kidneys are the only organs and corneas are the only tissues covered under the Ministry of Health National Organ Transplant Program. A tissue bank has not been established at this time, therefore the corneal grafts are imported from the United States. Our hope is to establish our tissue bank in the near future and to extend our transplant program to include other organs such as the heart, the liver, and the lungs. Almost anyone can become a donor. For persons less than 18 years of age, consent can be given by a legal guardian. Elderly persons, as well as persons with comorbidities which are well controlled, can also be donors. What does it mean to be a donor? Being a donor means that you are giving the gift of life to someone by donating your organs when you die, or in the case of a living donor, you are saving someone else with no risk to your own life. So what are common concerns about organ donation? If doctors know that I am registered to be an organ or tissue donor, will they work as hard to save my life? The answer is yes. The first priority of a doctor is to save your life, and everything possible is done to achieve this. Organ donation is not even considered until after death has been declared. Typically, the team involved in a person's care before death is not involved in the recovery and the transplantation process. There is a separate transplant team. Do celebrities and the rich move up the waiting list more quickly? The answer is no. A person's income, race, or social status are not taken into account in the allocation process. Also, the severity of illness, time spent waiting, blood type, and match potential are factors which determine the place on the waiting list. It is illegal to sell organs. A live donor, however, can choose who receives their organs. After donating an organ or tissue, is a closed casket funeral the only option? No. Organ procurement is similar to surgery. Each donor is treated with the utmost respect and dignity. There is no disfigurement to the donor's body, and the relatives can have an open casket funeral. Does my religion support organ donation? All major religions support organ and tissue donation. In fact, they regard it as an act of goodwill and love. Can I choose who receives my organs? Yes, a live donor can choose who receives their organs. If I am in a coma or declared brain dead, how do I know I won't eventually recover? Coma is different from brain death. Coma is a state of unresponsiveness which can be due to several reasons, but in a coma, you are able to breathe as well as generate a blood pressure and a heartbeat. Brain death, however, is an irreversible loss of all of these functions, as well as the function of the entire brain and the brainstem. All functions which are vital to life are lost. By law, a person who is brain dead is dead. So how do we sign up to be donors? Well, you can sign up by completing the forms available in the intensive care unit at all the major hospitals, as well as the Ministry of Health website. These forms are to be completed and can be submitted to the National Organ Transplant Unit at the Eric Williams Medical Sciences Complex. Remember, even though you signed the National Organ Donor Card, this merely states your intent to donate your organs. At the time of death, it is your next of kin who has the final decision as to whether to donate the organs or not. Therefore, it is imperative that your family and friends must be informed of your desire. In conclusion, the success of the National Organ Transplant Program is dependent on you. We hope that this presentation has encouraged you to become a donor and to share the gift of life.
Okay, so thank you, Dr. Ram Saran, for giving us all of that information about organ donation. Right. So now we want to open the floor to any questions that are in the chat. We have a little while to do that, but in the meantime, we have a few questions for the panel. The first one is, how can I protect my kidneys if I take medications to treat health conditions? Ms. Spencer, you want to answer that question first?
Yes. Thank you. So the medication that most people take are painkillers for chronic pain, acute pain. So the first piece of advice would be to consult your doctor. If you try not to use over-the-counter pain medications for more than 10 days, if you have not seen a doctor as yet, you're trying to avoid the prolonged use of painkillers that contain the mixture of aspirin, acetaminophen, and caffeine, so migraine medications. If you're taking painkillers, don't drink alcohol and try to increase the amount of water that you drink per day, and consult your doctor before taking any NSAIDs or non-steroidal anti-inflammatory drugs or higher dose aspirin. For other medications that you might be taking, again, consult the doctor that is treating you about what the effects on your kidney might be and what you can do along with your regular healthy kidney habits to keep your kidneys healthy, and make sure you get your blood testing done regularly to monitor your kidneys so that you can determine early if any kidney problems are developing.
Great, thank you for that, Steffi. I see in the chat we have a question. This is, I wouldn't call the names, but good night to the panel. Police officers often use energy drinks to keep them alert when they are on the job. Can this be detrimental to them later on in life with respect to their kidneys? Anybody want to take this question? Dr. Roberts, probably. You just need to unmute.
Sorry, yeah. Sorry, Dave. Could you just repeat the question again for me, please?
So the question is, good night to the panel. Police officers often use energy drinks to keep them alert when they are on the job. Can this be detrimental to them later in life with respect to their kidneys?
Well, I don't know that it will be absolutely detrimental, but this is all part of why one should be able to always have a regular checkup, because any early detection is really the key for this. I don't know if these drinks contain caffeine, and if they do, which is usually something that you take to keep you alert, and you're using that consistently and frequently, then I would think it would be detrimental to them later in life. But I believe that what one should be doing in cases like this, or in any instance, you should really be getting a regular checkup and ensuring that your kidney health is being maintained.
Just to add to that, Dr. Roberts, most of these drinks have a huge amount of caffeine in them.
Yeah.
So that should.
So they're not good.
Sorry?
Yes. Okay, so another question we have is, if a registered organ donor dies and their next of kin refuses to consent to donation, can the team proceed with the retrieval, and what are the subsequent transplantation issues? Dr. Ram Saran, you want to answer that first?
Okay,
can I answer that if Dr. Ram Saran doesn't want to?
Go ahead, Dr. Roberts.
Even if you are a registered kidney donor, it is my belief that your family ultimately gives the last consent. This is why it is so absolutely important that you speak to your family about your intention. So a follow-up is that once you decide that you're going to be registered to be a donor after dying, you need to be committed to be speaking to your family, your next of kin, that this is what you want to do. This is what you really want to do, so that they would know that really to give dissent after you have passed on, and it is possible that you could be a donor, would really be going against your wishes, and this is something that they would not do. As a matter of fact, we always used to tell them, don't forget to tell your family that we'll come back and twiddle your toes or haunt you if you don't carry on my wishes. So it is exceptionally important that you not just only sign up, but you speak to your family about what your wishes are.
Yeah. Dr. Roberts, as you're there, I'm seeing Dr. Alan Haynes is asking a question, probably best suited for you to answer. Who was the driver in Trinidad and Tobago for your transplant program? Was it government or the public?
It was a mixed. I think it was really mixed, but I think the major impetus initially came from the government, because if they hadn't set up National Organ Transplant Unit, we would not have been able to have got going. we had, prior to actually doing these transplants under the National Organ Transplant Unit, transplants have been done before. But what you found was that patients defaulted because they couldn't afford the drugs, they couldn't get the drugs. If they scraped up enough money and they went off to Pakistan and India, they would be able to do that. But on their return home, there was no follow-up, mainly because they couldn't always get access to the drugs, and we had no knowledge of their medical history. So when they became ill, it wasn't really a clear goal, a clear follow-up. Once national organ transplant was set up, then you had a clear streaming of what happens. You needed a kidney, you had a living donor, you signed up to be or you were put on a deceased donor list. Everything that was possible in the public system was given to you. So I would say that initially the government really was the driver, and most probably does continue to be the driver under the RHAs. The public, as well as the private sector, could come in and give the little add-ons, but to get it driven, you need to have, I think, the government.
Jolene, if you don't mind, in the interest of time, there are a number of questions that we can address in the chat. Some of it will be answered in the presentations to come. One of it is Dr. Striker will probably address this question, and if it's not answered, you can re-ask it. Good evening. What if a person gave an undertaking to donate a kidney? That person is murdered or involved in a fatal accident where they require an autopsy. How do you deal with that? And I think Dr. Striker will probably address that in a minute. Can I donate my organs? Can my donated organs be safely stored for my family, just in case the future they get a kidney problem? And unfortunately, the longest time that we would have would usually be 20 hours or so. So beyond that, no. Good. And the other question here is, what are the physical effects for someone who donates a kidney after the procedure? And I think Dr. Lynch will probably address those in the coming up. Could anybody help us to answer this question? Can someone donate their kidneys if they are diagnosed with kidney stones? Anyone want to take that question? Dr. Roberts, I think you might be up again.
Firstly, I think it depends on what kidney stone, what is the type of kidney stone you have. Secondly, it depends on what the damage that has been done to the kidney because you have had kidney stones. And thirdly, it would be if it is that there's something inherent that is going to cause you to form recurrent kidney stones. So essentially, my suggestion is, if you do want to donate your kidney, then when you are tested, if you do want to donate your kidney, you consult your physician, you consult NO2 and see if you are eligible to donate the kidney, because there are so many different facets to decide whether or not you can give your kidney if you have a kidney stone. So I won't like to say no outright. I would like to say yes as well. I think the whole situation needs to be assessed and determined.
Just to finish up with these two more questions before we move on to the next session. Good night to the panel. As it relates to a deceased donor, what is the time frame needed to retrieve a kidney upon demise of the donor? Anyone of the panel want to take it? Probably America or Steffi.
Right. Can you just repeat the question? I didn't quite hear it.
As it relates to deceased donor, what is the time frame needed to retrieve a kidney upon the demise of the donor?
I think to better answer this question, I think somebody more experienced and more hands-on, as I am still quite junior, should answer. I want to be able to answer.
Could I ask Dr. Hananan to tell us? I think he may be.
So in retrieving, once the process involves us to be able to diagnose that the patient is brain dead, and once we've agreed that we're going to take the organs, there are maximum time they would wait is usually around 90 minutes. Usually seen in the donation after cardiac death, but more times in a deceased brain dead patient, it is a control setting where you would, you would pronounce the patient and has passed on, and then we will look to retrieve the organ once the patient is dead. But the longest time is around 90 minutes. And the other question is, has a policy been drafted to widen the ambit of the legislation to expand beyond just kidney and corneal transplant? And if not, is this envisioned? Probably Dr. Roberts is best to answer that.
You say a policy. We don't have a policy, and I do know that Dr. Lynch has great plans for the National Organ Transplant Unit. So I hope, I'm sure that eventually that will come under. But the regulations to allow for different organs to be harvested, that had been done in the initial stages. We just started with kidneys and corneas, and we have got a bit stuck. But in years to, well, hopefully in time to come, we are going to advance, because as you would have seen in the presentation, several people can be helped from just one deceased donor. We don't want to limit ourselves to kidneys.
Then I think we can hand over to the other. If you're okay with that. Go ahead.
Yeah, okay, so thank you for all the presenters for the first session. This was our first half of our program. So we know that everyone has a lot more questions. We will put up a link so everybody can email the questions, and relevant people will answer them, right? So for the next session, your chairpersons will be Dr. Camille Sanderson and Nurse Anne-Marie Ragati. Are you all here?
Thank you. Thank you, Ms. Moore, for the welcome, and welcome everyone to the second session of our program. In this session, we'll be hearing testimonials from individuals whose lives were affected one way or another by kidney disease, dialysis, and kidney transplants. The first testimonial is entitled, "A Loved One Gave Me a Second Chance," and it will be delivered by Mr. Mikael Wilson. Mikael Wilson is a 22-year-old Trinidadian who was diagnosed with end-stage renal failure in 2013. He subsequently received hemodialysis treatment for 1 year. In January of 2015, he received a directed living kidney donation from his mother, Tricia. This gave him a second chance at life. In 2021, Mikael graduated from the University of the West Indies, Cape Hill, with first-class honors in a Bachelor of Health Science with a major in community health. While at Cape Hill, he served in the Medical Students Association as the Health and Safety Officer. He was also a lead soloist in the Cabbage Choir, and he participated in many community volunteer programs aimed at sexual health and non-communicable disease education and screening. Currently, he is pursuing a master's in occupational therapy at the University of the Southern Caribbean, where his goal is to become a registered occupational therapist in the field of adult physical rehabilitation. However, his time spent working so far with children is making him lean towards the field of pediatrics. When he is not studying, you can either find him working on some form of visual art, graphic design, or in his garden experimenting with new agricultural techniques. Here's Mikael Wilson.
Hi, I'm Mikael Wilson. I'm 22 years old. I'm currently doing a master's. I really love agriculture and gardening, and I had a kidney transplant. This is my story of how a loved one gave me a second chance. In 2013, I was diagnosed with end-stage renal failure at the Eric Williams Medical Science Complex. At the time, it was extremely scary, and to this day, we have no exact cause as to why I would have gone into end-stage renal failure at such a young age. However, after the diagnosis, I was on hemodialysis for about 1 year. Afterwards, I joined the transplant recipient list in a search for a kidney. However, the answer was right here at home with my family. In 2015, January, I was a recipient of a kidney from my mother. And many people often ask me what it's like, but it's so hard to put into words sometimes, because many people say, oh, it's your mother and she gave you life and she gave you life a second time. And it's very much that often people don't think about the kidneys, but we often forget how important a filter is in any machine, air conditioner, a car, or even your irregular day Brita filter. If the filter isn't working, the whole system shuts down, and the exact same thing happens in a human body. When my kidneys stopped working and I received a kidney from my mom, I had a complete life change. Before, while I was on dialysis, I was always tired. I had to go to the hospital several times a week for my treatments. I used to miss school. I wasn't able to participate in a lot of different activities that I would have wanted to as a teenager. However, since I received my kidney transplant 7 years ago this year, I can really say that I live a life just like anybody else. However, I still have to take medication every day to maintain the transplant and, of course, take care of my health. And that is something that we often don't think about. Every day we make our small decisions that determines our long-term health. And with our kidneys, that organ really shows how making small changes every day can help. Kidney disease is on its way to being the 5th leading cause of death worldwide by 2040. And every day we have opportunity to make small changes so that we can live a long and healthy life. So it's not about making one huge change now, but making small decisions that are beneficial to your health every day. And you wouldn't have to need a loved one to give you a second chance. But I'm so thankful and I'm so blessed to say that I was given a second chance by my mother. And I really want to dedicate this World Kidney Day to her for giving me a second chance at life.
What a wonderful testament of love, sacrifice, and hope. So let's continue to Kathleen Tyson. She is the wife of the late Courtney Tyson. She's originally from Sandy Grande. She was a preschool teacher for 32 years, and she has been a widow for 6 years. When her husband passed, they were married for 24 years. She had the privilege of donating her kidney to her husband. As a result of a healthy lifestyle, she's also a strong believer of Christ, and with him, in life, nothing is impossible. We have just heard from one of our kidney recipients. Let's now hear from one of our selfless donors who bears witness to the statement, "I have a great life after donating my kidney."
Good evening, everyone. I'm Kathleen Tyson, and I've been a kidney donor for approximately 15 years. My husband, Courtney Tyson, was diagnosed with renal failure at a very early stage of our marriage. It was a long and tough road, but I never thought of giving up. I said to myself, the Lord never gave you more than you can carry. He did dialysis for 10.5 years. In January 2007, we were introduced to the National Organ Transplant Unit at Montauk Hospital. We had a meeting with the staff, and it was a very comfortable experience. Donating my kidney to Courtney was never a second thought. We decided to get tested to ensure that I was in great health to endure such a procedure. The surgery was done on June 18, 2007, which allowed my husband to live a full life for a further 9.5 years. He is now deceased not because of renal failure, but pneumonia. I am comfortable living with one kidney. I live a normal life as I maintain my weight, drink a lot of water, and eat healthy. I feel great and I'm loving life. I would encourage anyone to become a donor as long as you are able to do so. I think it is a blessing to extend someone's life as God would permit. It is almost 15 years, and I give thanks to the Lord daily for bringing me this far. I actually wear this green band, which identifies that I am a kidney donor that says, donate life. Thank you for listening.
What a wonderful selfless act. So we're about to hear next from Mrs. Jillian Youngson. Her piece is called My Family Gave Life and We Got Comfort Through Our Daughter's Passing. Mrs. Jillian Youngson is happily married to a wonderful husband, and they were blessed with 6 beautiful, intelligent daughters and 2 amazing grandchildren. She has a saying, her family is her life, and her life is her family, and her family is her life. She is a florist and a humanitarian at heart. She is involved in numerous charitable endeavors, projects, and fundraisers. But giving doesn't always come easy, and sometimes it often requires great sacrifice. She experienced this firsthand when faced with the decision to become a donor family a few years ago. She had just tragically lost her first daughter, and the decision to donate her kidneys while in the throes of grief was not an easy one, but it was undoubtedly the right one. Her family could not turn back time, but perhaps they could give time to others whose lives depended on a kidney donation. During that devastating time, it offered a small silver lining that even in their daughter's passing, she would continue to contribute positively to society and profoundly impact the lives of others for the better. That fact continues to comfort this family. Let's hear from Mrs. Youngson.
Hello, the topic for today is My Donor Family Gave Life and We Got Comfort Through Our Daughter's Passing. Now, this is not an easy topic to talk about, but I agreed to talk about it in order to encourage others to do what we did as a family. At the time, it was yes, a difficult decision, of course, because our daughter was young, and we have 6 daughters, but our daughter was young and she was bright and she had a wonderful future ahead of her, happily married, 2 wonderful children, and because she died so suddenly, we had to make a decision of if to give her kidneys because she was healthy and could benefit someone else. So her husband, was his decision to make, being the next of kin, and he involved all of us. And as a family, we decided that it was the right thing to do because when we considered what she would have wanted, we realized that that is what she definitely would have wanted because she was a kind, loving, caring person, very charitable, always thinking of others. And she would have definitely wanted to make a difference. And she would have felt really good knowing that, she made a difference to 2 people. She gave her kidneys to 2 different people, and she also was able to change the lives of not only 2 people but 2 families because she would have given the people that she gave it to, the recipients, a longer chance of living and of living a quality life, so that she really would have made a positive difference, and definitely she would have wanted that for sure. Also, she was a biologist, qualified biologist, so that in that way, the science part of it I knew would have meant a lot to her as well. And then the other angle of it too is that later on, I was able to see the other side of it now. We were on the giving side, choosing to give, and I was able to meet years later a friend of mine who had lost in touch with But in helping her, she was in need of help and I was helping her, I discovered her story. And her story was one that in her 20s, she needed a kidney. And when she was lucky enough to receive one, the kidney lasted so long that it really extended her life so that she was able to live an extra 30-something years. And she lived a quality life and she was able to really do everything and enjoy life. And all because someone decided to give them their kidneys to her. So that I saw that side of it and the impact it made on her life and on her family life and the positivity of it, so that I really would like everyone to consider that if they are put in this position, that they would definitely donate their kidneys and encourage their family members to do the same, because it really makes a world of a difference and it's a wonderful gift that, if you have the opportunity to do so because your kidneys are healthy, that you should definitely consider it. Thank you.
I really want to thank you for even sharing about that, because it really showed how they made a difference in two people's life just by that selfless act. And so let's continue to Carmen Abdeno. She's a registered pharmacist with the Pharmacy Board of Trinidad and Tobago, with over 30 years of client-facing experience in the domain of retail pharmacy. Currently, she's a senior licensing pharmacist in Starlight Pharmacy for over 7 years. She has worked extensively as a certified breastfeeding counselor with the Breastfeeding Association of Trinidad and Tobago, a registered NGO, for over 25 years. Her last position was the chairman of that board for 2 years before resigning from the organization. On the 4th of January 2010, she received the gift of life after waiting 2 years for a deceased kidney donation in Orlando, USA. Prior to this, she was on hemodialysis for 6 years. The 4th of January 2022, she celebrated 10 years post-transplantation. She is passionate about education in diabetics and hypertensive concerning their kidney health and is an advocate for transplantation. Once again, let's hear from Carmen Abdeno speaking on "A deceased organ donor saved my life."
In January of 2001, I was diagnosed with end-stage renal disease. Both my kidneys no longer functioned to be able to remove waste products from my body, nor perform any of the other functions that kidneys do, such as blood pressure regulation. For 2 years, my nephrologist, Dr. Leslie Roberts, staved off dialysis for as long as possible until September 2004, when it became absolutely necessary. My dialysis sessions were 4 hours at a time, 3 times a week. This severely impacted both my physical and my professional life. Dialysis is not the only form of renal replacement. The best option for patients is always transplantation. With Dr. Leslie Roberts' assistance, she reached out to a US hospital for my possible enrollment in a deceased organ program. Fast forward, I was accepted into the program and the waiting game began. 2 years later, physically, emotionally, and mentally exhausted, I finally got the call to come up to be transplanted. The gift of life was secured on the 4th of January 2012. A deceased organ donor identified only by a number was given to me. The gift of a second life. The odyssey from dialysis to transplantation is an amazing journey that tests the limits of human strength and courage. It requires commitment and faith, as well as mental, emotional, and physical endurance. If you can complete that journey, you can put your mind to anything that you have to do. It is one of life's greatest challenges, and amongst its rewards is certainly life itself. Organ donation defines love, generosity, and life.
Heartwarming testimonials. So the title of the next presentation is Life After Donating a Kidney. This will be brought to us by Dr. Sean Lynch, who is a general and transplant nephrologist. He is also currently the director of the National Organ Transplant Unit. Dr. Lynch completed his undergraduate and internal medicine postgraduate studies in Trinidad and Tobago. Following this, he completed double fellowships in nephrology and kidney transplants at the University of Toronto. He returned to Trinidad and Tobago in 2013 and has been working in both public and private practice ever since. So over to you, Dr. Lynch.
Hi, good evening, everyone. My name is Dr. Sean Lynch, and I'm a transplant nephrologist and currently the medical director of the National Organ Transplant Unit. My talk this evening is entitled, So You've Donated Your Kidney, What Next? Firstly, I'd like to report that I have no conflict of interest. So, you've donated your kidney, and what can you expect in the next few days to the next few months to long term and years in the future? So in the first few days, after you've donated your kidney, you return back to the ward, and the major complaint really, or the major problem or the major concern is that of pain. And we manage this in a couple of ways. One, we use a system called patient control analgesia, where patients are allowed to press a button and release medications to help control their pain. The second way to control pain is via just giving you medication when asked for, either oral or intravenous, which is called PRN pain medications. So the real issue really is how severe is pain post-kidney transplant. And this was an interesting study done and published in the American Journal of Transplantation in 2020, where they looked at patient self-reporting of pain following laparoscopic donor nephrectomy procedure. And this procedure is the procedure actually that we use at NO2 to remove a kidney from a living donor. And what you can see from here is in the first couple days following a kidney transplant, especially day one, there was a significant proportion of patients who reported severe and moderate pain. But over time, particularly from day 7 onward, this percentage decreased significantly, in that the percentage of people who reported severe pain became almost minuscule by 28 days post living donation, and most pain was either mild or none at all. And this continued all the way out to 56 days when they followed these patients. So this is suggesting here that whereas pain may be a bit more of a concern in the early course of living donation, certainly by 1 month, it's quite minimal. This study also asked patients to describe their pain anywhere from tender to punishing and cruel, and this is just the different ways people describe the pain that they have following living donation. Now, what I can say is that in our local experience, pain is seldom an issue. the majority of our patients are home by day 2 or day 3 post-kidney transplant, and out of the 20 transplants I've been involved in, I can only think of about 2 patients who had to stay beyond that. And from my anecdotal experience, I would say that pain is seldom an issue within our program, though I must admit that we have not formally studied it. However, the most common concern really amongst people who donate kidneys is, what's going to happen to my kidney function? Am I at risk? Am I at risk of losing kidney function? Am I at risk of ending up needing a kidney transplant myself in the future because my kidney has deteriorated following donation? So if you look at a kidney transplant, at the time of kidney transplantation, what happens is that your kidney function is reduced by 50%. So let's say you had 100% kidney function. At time 0, it's down to 50%. But what happens in the next 3 months, and we know this because we've studied it using different models, is that there's improvement in your kidney function, whereas at about 3 months you end up with about 65 to 70% of what function you had initially. So if you had 100% kidney function to donate, you end up with about 65 to 70% of that function at about 3 months. Now, an interesting study that came out in 2018 in the American Journal of Transplantation showed that there seemed to be improvement even beyond that 3-month period in people who donated kidneys. Whereas between 6 weeks and 5 years, the average increase in their GFR was about 1 mil. You can think of GFR as about as 100 mils of GFR is about normal. So what is happening here is you have just over 1% of improvement in kidney function in the first 5 years following donation. In the subsequent years, this tails off to be close to minimal between 10 and 20 years, but most importantly, showing that there's no loss of kidney function until at about the age of 70, when the kidney function seemed to decline. Now, it's important to understand that these people are starting at a lower value, because if they have given up their kidney, they start at 50%, at 3 months they're close to 65, 70%, and then they're improving slowly over time, whereas the general population is at 100% going down. So this is an interesting French study that actually looked at survival amongst patients who donated kidneys. And what it seemed to suggest is living donors lived longer than the general population. And that seemed to pan out up to 40 years post-donation, when the survival seemed to be equal. So I would often tell my patients this, and I would say, hey, you know that if you apply for life insurance, for instance, you should get it immediately, because the statistics show that you actually live longer than people in the general population. And this is 100% true. However, comparing living donors to the general population is indeed unfair, because living donors are a highly selected group of patients who are quite healthy, and therefore we are comparing them to the general population, which will include people with a lot of comorbidities. So this was an interesting study that tried to truthfully look at the situation, comparing living donors with healthy non-donors, and also patients in the general population who would have had comorbidities. And essentially what it shows is that though the living donors did better than the general population, the living donors did not do as good in terms of the development of end-stage kidney disease as healthy non-donors. Now, it must be noted that the absolute risk here is still quite small. So although living donors had a higher rate of end-stage kidney disease than healthy non-donors, the absolute value was quite small. This was in the order of 0.45%. So 0.45% of people who donated their kidneys ended up on dialysis. And although it was higher than healthy non-donors, the absolute value is still quite low. So this is suggesting that despite the fact that you may have a slightly increased relative risk relative to these people who are non-donors, your absolute risk of developing end-stage kidney disease from donation is quite low. Okay, so at our unit, we bring back our living donors for assessment of their kidney function with both blood and urine testing at months 1, 3, 6, and 12 post-living donation. What we've realized is that a lot of them actually don't ever turn up for their 1-year review, and most of them stop after 6 months. But that's okay in a sense, because Trinidad is quite a small society. So we do get feedback on our living donors, and out of our close to 200 transplants, of which 150 or so are from living donors, we have had no problems with anybody having kidney dysfunction post living donation, and certainly we've had nobody end up on dialysis. So in summary, living donation kidney transplant is quite a relatively safe procedure with a very low risk of both acute problems and a low risk of long-term complications of developing kidney disease. Thank you, and I'll be happy to field any questions.
Thank you, Dr. Lynch, for that informative presentation. So our final presenter is Dr. Bridget L Cox Striker. She is a UK-trained specialist in anesthesia and intensive care, holding an executive master's degree with a distinction in business administration and an international master's in donation and transplantation, University of Barcelona. Through her team's efforts, Trinidad and Tobago had its first forensic deceased kidney retrieval in 2012 and the first deceased donor quadruple retrieval of both corneas and both kidneys in 2017. She was Trinidad and Tobago's first representative of the Starlight Conference in Mexico and the CIO-DC Conference of Leadership Workshop in China 2019. Her joint publication, Regional Report on Organ Transplantation in Trinidad and Tobago, was published in September 2020, the issue of Transplantation. She's a member of several international medical societies. So let's now go to Dr. Bridget L Cox on the legal, ethical, and religious aspects of donation and transplantation.
I am Dr. Bridget L Cox Striker from Port of Spain General Hospital in Trinidad and Tobago, and I am looking at bridging the knowledge gap to better kidney care through understanding the legal, ethical, and religious aspects of donation and transplantation. Our learning objectives are the ethical, the legal, and the religious views of organ donation and transplantation. Sadiuddin et al. Wrote in the Lancet about the hazards associated with transplant tourism, where recipients from rich countries went to much poorer countries and got mismatched organs, had high rates of infection, and many of the living kidney sellers ended up with post-op infections, depression, suicide, and kidney failure. Trinidad and Tobago was also part of that problem. And the terms were coined to frown upon these practices. So there was the term transplant commercialism, a practice in which an organ is treated as a commodity to be bought and sold. Organ trafficking, where organs were removed from living or deceased donors without free and informed consent, and transplant tourism, which is the movement of organ donors, recipients, and transplant professionals across borders for the purpose of organ trafficking and transplant commercialism. And here in the map on the right, we see the blue countries, which are where the typical recipients come from. High income, male, 48, average age, going to the red countries, which are the typical donor countries, for example, the Philippines, young persons, and the average 28, mainly main gender, and annual income of less than 500 US. So Trinidad and Tobago is a participant in the International Summit on Transplant Tourism and Organ Trafficking in INCIBL in May 2008, and Dr. Leslie Roberts was a signatory. The Human Tissue Transplant Act 13 of 2000 was an opt-in system that defined brain death, established the National Organ Transplant Unit, and made provision for the removal of human tissues, organs, and blood for transfusion. There's a strict priority order for relatives, and it permits transplantation between relatives and non-relatives. The types of death, very important. Most people understand the term cardiac death. My heart stops beating, so I've died. The brain stem death is a concept that is defined in law as the absence of function of the narrowest part of the brain stem at the base that houses the vital centers for breathing and generation of a heartbeat and blood pressure. You must have an irreversible known cause of coma. You must be able to not breathe. Can't breathe, cannot maintain blood pressure, and you require a ventilator to breathe artificially, and you require drugs to support a pulse and blood pressure. In order to confirm this type of death, several tests have to be done. They must be done twice, and they can only be done by 2 senior doctors with at least 5 years experience. We also need to understand the term forensic versus natural causes of death. So natural causes of death are from internal causes such as diabetes, whereas forensic death is unnatural death, normally caused by external causes, which can include an intentional injury such as poisoning, suicide, homicide, or unintentional injury such as an accident. So look at some cases of unintentional forensic demise. Do any look familiar to you? The forensic pathologist has a very important role in forensic case donation. Why? Because they must examine the brain dead person prior to organ or tissue retrieval to ensure that retrieving the tissue or organ will not adversely affect the postmortem examination at the Forensic Science Center. The forensic pathologist will then document this in the patient's notes. The police have a very important role in ensuring that forensic cases become organ donors. Therefore, part of breaching the knowledge gap is to ensure that the investigating officer's name is known and documented in the notes. We must have their badge number, rank, police station location, and the landline, and if possible a cellular contact, and his or her senior officer's name in case the officer is off duty at the time of brain death. The officer should also know the direct line to the ICU. And this is a very important thing I'm saying because we have had cases where we are trying to ascertain an officer's contact information, and there is resistance. Apparently, an officer may think the doctors are checking them out. It's not so. There is a reason. The police officer is responsible for prompt police report on the circumstances that precipitated brainstem death of the patient. This will be submitted to the coroner, who will decide if they can proceed based on, among other things, the same police report. There is a limited time frame for donation of all brain dead organ donors are unstable and can suffer cardiac arrest, which means the heart stops beating in spite of the drugs at any time. Organs have a limited time to be transplanted after retrieval, so time is essential. The coroner is a judicial officer who will review the patient's medical data, who will ensure that there is a confirmed cause of brain death, who will confirm that all the legally required tests to confirm and validate brain death were done by 2 senior qualified doctors twice. They will also confirm that consent was given by the legal next of kin. They must confirm that Form H, a special form, was signed by the hospital's designated officer. This is a person who independently checks with the relatives to make sure that they have understood the consent form they have signed to give permission, to confirm that they're doing it of their own free will, and this is something that the deceased relative would have liked to have done while they were living or would not have objected to. So each public hospital has a designated officer. The coroner will also examine the police report, and the coroner will finally issue written approval for deceased donor organ retrieval. This slide quickly looks at the different organ donation programs in the Caribbean, and we see that Trinidad and Tobago, Cuba, and Dominican Republic are the only ones with living and deceased organ donation programs. These 3 countries, together with the Cayman Islands, have their legislation drafted. That's their 4th column. However, some jurisdictions are still to start their programs. So let's use this opportunity to say kudos to our police in our previous forensic organ and tissue retrievals. Special mention must be made of ACP Dick. ACP Dick was the first police officer who dealt with an organ, a deceased organ donor who was a forensic case. And when I called him and said, the family has given consent, but we don't know how to proceed, ACP Dick just ran with it. He said, Doc, I don't quite understand it, but this sounds like something really important. And he just ran with it. He made waves to make sure that we got everything done in a timely manner, prepared, all reports ready to go to the coroner. And he called up judicial officers to make sure that things were put in place to get this thing approved. So ACP, Wayne Dick, wherever you are, we want to thank you, because without your help, we would not have had our first deceased forensic organ donor, from whom we got 2 kidneys. And ACP Dick, long afterwards, for donors, and these donors, you see a number. The number 1 refers to the first that we had in the country, and number 3 shows the number as a deceased donor they were nationally. So like donor 2-4 was the 2nd forensic deceased donor and the 4th deceased donor in the country. All right, so ACP Dick spread his knowledge to many other officers in Valencia, St. James Police Station, Sangre Grande, and even assisted in Old Range Police in Tobago. Yes, we were so sad when he retired, and we saw other officers rising to the challenge: Galindo, Cooper, Samuel, DCP Philip, Corporal Bash, Garcia. Thank you, gentlemen. Kudos for our forensic pathologists, and special mention is made of Dr. Valerie Alexandrov. His help allowed us to get our first forensic deceased donor in the year 2012. And since then, there has been a steady stream of these donors. Dr. Yvonne Devines, Dr. Eslyn McDonald-Boris, and Dr. Somyu Gajula are some of the other forensic pathologists who have assisted coroner and chief magistrate, Ms. Marcia A. Caesar, was our first coroner involved in deceased organ retrieval, and current post holder is Miss Maria Buswell Cadell. Does my religion support kidney donation and transplantation? Let's look at a few of them. Hinduism. Donation and transplantation is consistent with belief in life after death or ongoing rebirth. Dahan, or selfless giving, is the third of 10 niyamas or virtuous acts. And these selfless deeds accumulate good karma. Dharma, or righteous living, is that which sustains. And donation of a body part is the highest form of charity or seva. In Islam, in the Quran, it says if anyone saved a life, it would be as if he saved the life of the whole people. So Allah ordered ihsan, or compassion, to all human beings, including non-Muslims. Donation is a continual charitable act, or jariyah, or a gift that keeps giving. So there have been fatwas issued from the highest council of scholars in Riyadh, Saudi Arabia, which says it's permitted to transfer whole or part of organs from a deceased to another person if the need of such transplant is critical. It is similar to fatwas issued in Egypt in 1989, Kuwait and Singapore, and in Trinidad and Tobago by the ASTRA just in 2021. Islam permits surgery on corpses. For example, if you want to save a baby whose mummy has died, a post-mortem cesarean section does not violate the sanctity of the body. It is permissible to delay funeral rites for organ donation, and an organ recipient who commits a misdeed is solely responsible for his actions, not the organ donor. I was actually asked that question by a family. The majority of Muslim countries around the world support organ donation. Christianity supports organ donation. It is seen as an act of love, altruism, generosity, sharing, giving, and they recognize that the physical body is not part of the afterlife, and therefore the perishable cannot inherit the imperishable. So most Christian denominations support organ donation after. The Sai Baba, the Baha'i, Buddhist, Jewish, and Sikh followers have support from their religion for organ donation and transplantation. This crystallizes yet another care option for patients living with end-stage renal disease. Living or deceased donation and transplantation. Thank you.
Okay, so we're well past our time, but we're asking for a few more minutes from you guys to be able to allow a few questions to the last two presenters. We encourage you to type your questions in the chat. Dr. Lynch and Dr. Roberts are busy trying to answer them as we type them up. But we have a few questions specifically to the last two presenters, and we will start with a question to Dr. Lynch. The question is, should I donate my kidney and years later subsequently develop kidney failure? What are my options?
That's a fantastic question. So of course, your option, your foremost option should be transplantation. And if you have a living donor, that's great. We can evaluate you and we can work you up for a living donor transplant. However, in most first world countries, and we have taken the decision to do this as well as at No2, if it is that you have donated a kidney and something has unfortunately become to you where you develop kidney failure and you don't have a potential living donor, then we float you to the top of the deceased donor list. So you will not have hopefully any long wait time. Once you are eligible, once you are well enough and you're fit enough, you go straight to the top, and therefore the first kidney within your blood group that hopefully you're compatible to, you get. So we float them to the top of the deceased donor list if unfortunately they don't have a living donor.
We have one from the chat. This is from Melissa. Good night, host and panelists. Is there a criteria to become a donor, such as age of the person, comorbidities, the tests that have to be done, the operation to see if I am eligible?
As I said, living donors are a highly selected group because our fear is if you donate a kidney, we don't want you to become or to develop renal failure yourself. So certainly we don't accept patients who are diabetic because their risk of renal failure is very high. The different tests that we do, and once you pass those tests, you're usually allowed to donate. With regards to age, there's no age cutoff per se, but as you get older, you're less likely to be well enough to donate a kidney because there's natural loss of kidney function with age. So after the age of 25, each of us is losing a small amount of kidney function, some more than others, and it depends on where you start. So remember, you must have enough kidney function to be able to give someone some of yours. So therefore, older donors tend to have less kidney function, and that sometimes make them ineligible, or they may have comorbidities that are unacceptable. But we've had a 59, 60-year-old donor who gives to her husband, who's a little older than her. And therefore, what we do is, as I say, once you're good enough, you're old enough, we don't discriminate, we don't practice ageism. If you present yourself for donation and things look good, we do a workup and we can measure your kidney function. And if everything turns out okay, then why not? We accept you as a donor.
Thank you, Dr. Lynch. Our next question is to Dr. L Cox Striker. How do we ensure that living unrelated donors are not donating a kidney under duress or it's being trafficked?
Okay, there is an ethics committee. The ethics committee, it normally consists of a surgeon, physician, pastor, psychologist, layperson, and a lawyer. The person who is going to become a living donor, that person has to have a psychological assessment to make sure, first of all, they're mentally sound. And as part of the interview by the ethics committee, and in countries where they don't have their organ donor laws yet formulated, this is what they use as a sort of check valve to make sure that everything is not underhand. So that they would have to appear before that committee to make sure that they understand what they're doing this of their own free will, and that there is no commercial benefit, financial or otherwise, to be achieved as a result of this donation. And this is particularly important in people who are unrelated. We recognize that when we talked about organ trafficking, many of the people who were victims of organ trafficking did not know exactly what was being done to them. Some of them were like migrant workers who their passports were being held by their employer, and as a condition to be released or give back your passport, you had to give an organ by force. And sometimes they didn't quite understand the terms or the implications. So I hope that answers your question.
Thank you, Dr.
If I could just say one thing.
Just say something. Sorry.
Okay. Probably Leslie's going to address. It's not a pastor on the ethics committee. It's a member of the interreligious organization. So usually it's somebody of maybe any faith, but it's a representative from the IRO. So we if somebody wants somebody from their particular faith, that could be also facilitated.
Just two things I just wanted to mention. One of the people on the ethics committee was generally, if I remember rightly, somebody who was a donor advocate, and that person didn't necessarily have to be a lawyer. The other thing I wanted to mention is that the question was asked who drove the transplant program in our country. And I think the impetus to have transplant program driven was because of our bad history with so many of our patients prior to No2 being started, going off to India in the first instance, and then Pakistan, and then back to India, what I call the Eastern Trek, and having such, poor results that, the country really could not, we were known almost as if we were going to take people's kidneys. And because of that, that really horrendous experience, I would think in the early 90s and the late 90s, that we really moved forward quite swiftly with National Organ Transplant Unit and doing transplants here in Trinidad.
I also mentioned a little bit about it on the slide, one of my slides. Yeah, I put some of the
yes, I had spoken about it when I had presented in the in the intermediate course of, okay, that was really quite a poor time in our history.
Thank you all for that clarification. We have one more from the chat, and a nice one. Does having diabetes or hypertension automatically disqualify you from becoming an organ donor, whether living or deceased?
I just answered it in the chat actually, but yeah, having diabetes disqualifies you from living donation, not from deceased donation actually. Hypertension, we do accept hypertensive living donors, but they must be well controlled and have no evidence of what we call end organ damage. So that should answer the question.
The other thing I would like to mention with the deceased donors, there are people who have abnormal blood sugars or blood pressures that are not necessarily diabetic or hypertensive at the time of a brain death. Sometimes it's related to the treatment that they are on or as a complication of brain death. So it is the whole picture is looked at. And in addition, we would look for other things to make sure there's not contraindication to deceased donation, such as a patient having HIV, having hepatitis B or C.
Okay, Dr. Albert, we think you could take one more quickly. The question is, do the Orisha accept organ donation?
Okay, I have looked extensively to see if I could find anything in the literature about the Orisha concept with regard to organ donation, and I could not find anything. So I did a survey sometime last year where I did religious leader organ donation survey among religious leaders. I attempted to get 20 of the denominations that are listed as faith-based organizations in our country. I managed to get 10 of them to participate. And there were some Orisha leaders I contacted, and they were very hesitant even to look at the presentation that I sent them. And we tried to, I invited them actually to come to this. I don't think any of them came to this meeting, but part of it is that they see it associated with organ trafficking and something evil. And so I said, well, knowledge is power, and part of us learning about something that we're not too sure of is a way of helping us to make a sound decision about it. But I was not able to convince them, unfortunately. So, but having said that, I believe that the education of religious leaders about organ donation is probably one of the modalities that we can use in getting persons to accept donation, because many people look up to their religious leaders. They feel, hey, I'm not doing that because my religion does not accept it. And when the information is actually shared, when the people realize, but wait, this is something good, And there were faiths that I didn't know believed in organ donation who actually said, yes, this is something we believe in. So one of the things that I think we should be moving towards as a nation is looking to see whether we can have an actual coming together of religious heads. And a lot of them who participated in the survey I did actually were willing to have that sort of discussion among their members to make a statement with regard to what their faith believes in with regard to donation and transplantation. I actually, this study I did, I have sent it up to CAFA for their conference. I don't know if it will be accepted as one of the presentations. I hope that answers your question.
Okay, thank you, Dr. Elcock. We'll be posting an email address, I believe, so that if there are any other questions that we didn't get to, you can send it via email and someone of our panelists will answer it sometime in the near future. Okay, so to end our program tonight, we will be hearing our vote of thanks by Dr. Sasha Hines. She's actually a dear colleague of mine, works at the Port of Spain General Hospital in the Anesthesia and Intensive Care Department. So Dr. Hines.
Hi, and good evening to everyone. I'd like to take a moment just to say thank you to everyone who has attended and participated in tonight's session. Thank you for your questions and for the rapport and the dialogue that was created as a result. Our theme this year is Kidney Health for All, and the information that we received has certainly bridged knowledge gaps. It has equipped each of us with the information that we need to better maintain our kidney health. I would like to say thank you to each presenter who took the time to provide the very valuable content that we sat and learned from today. Thank you, Nurse Spencer, Doctors Roberts, Ram Saran, Lynch, and L Cox Striker for all of the knowledge that you poured out to us all. Particular gratitude is extended to each person who provided the eyewitness reports that we all learned from and we all really felt impacted by. I would like to thank Mr. Wilson, Mrs. Tyson, Ms. Young Singh, and Ms. Abdel Noor for what you all brought to our discussion. We also want to express appreciation to our chairpersons, Drs. Hananan, Dr. Sanderson, and the nurses who participated and kept our discussion going, Nurse Moore and Nurse Ramgati. Thank you very much for your coordination that was done with such grace and poise. As we come to a close, let us all remember the importance of our kidneys to our quality of life. Let us be mindful of what is involved in kidney care. Let us be on the lookout for each opportunity to gift life. And let us be sensitized to the legal, ethical, as well as religious considerations that are to be navigated surrounding each donation and transplantation. Thank you to all and have a good night.